This is your host, Mark Lieberman of the show The World According to Mark, brought to you on WPVM FM in Asheville, 103.7, streaming globally on WPVMFM.org. Today, I'm happy to welcome Karen Sanders. It's Sanders, not Saunders, because there's no you there, correct?
Correct.
Thanks for being on the show, Karen.
Thank you, Mark.
Let me tell people why I was interested in having you on the show and why you were kind enough to be here to talk about the world of patient advocacy. We're going to figure out what that means with Karen's help. But Karen has a distinguished career. She's been in the healthcare world for many years. I don't know, around 1975, would that be accurate?
That'd be about right.
Around 1975. She went to various schools, obtaining various degrees, which we'll talk about. And she's been various personalities and things in the healthcare world. And she is a prolific writer, speaker, but she's her main claim to fame, I guess, is the patient advocacy thing. So Karen, why don't you tell us a little bit about your background, a little bit more than I was just saying, and then we can talk about what is a patient advocate and why is it important to know one.
Okay. So would you like to know why? Well, I'll just say I became a nurse, and I went to Oldham University in Norfolk, Virginia, graduated there with a baccalaureate in nursing. And then I worked a while and went back to school and got my master's degree in nursing from the University of North Carolina, Chapel Hill. Then I worked in big medical centers at the front end of my career, Medical College of Virginia, which is now Virginia Commonwealth University in Richmond, then to University of North Carolina Hospitals in Chapel Hill, then the University of Virginia Hospital in Charlottesville, and then Mission Health, where I worked there for 16 years in a variety of different jobs. And then after that, I also worked as a clinical team director for a medical rehabilitation unit with Care Partners. And then I was an administrator for Asheville Radiology and Pain Management, Carolina Vascular, for about 4 years. And then I was a director of nursing for a small rural hospital called Transylvania Regional Hospital, which was also bought by HCA Mission. And then I knew I always wanted to go into private practice. So I was also a nursing instructor at a private for-profit school called South College. And then in 2015, I started my own private practice as an RN patient advocate. So that's my overview of my career.
So I was going to ask you a slightly comedic question, but I'll try to tone it down a bit. I was going to say, so is the best way to become a patient advocate is to spend a very significant portion of your time in the healthcare business, providing care, treatment, and so on and so forth, and then to become concerned, disgruntled, and decide, the heck with this. I know how the game is played. Now I'm going to be a patient advocate.
So, interesting question. So one can become a patient advocate or an RN patient advocate. And there's a lot of literature out there about people who want to do this work. And people ask me, how do I find one? And the answer is you always want to look at each person's education. You want to make sure they have healthcare training or education. And then you look at their experience, and you want someone who's got a few years under their belt as a working in healthcare. So that could be nursing or pharmacy or dietitian or someone like that. So when you're trying to find a patient advocate, you want to focus on education and you want to focus on their work history. And in terms of becoming an RN patient advocate, this field as an RN patient advocate is fairly new within maybe the last 15 years. There were very few schools training nurses to become an RN patient advocate when I embarked on my journey in 2015. Now there are multiple schools teaching nurses to become RN patient advocates, and they're very expensive. And now they're tending to be graduate level programs, but they're highly expensive, like $10,000 to $20,000 plus. So there are programs available that you can take that offer all of the parts that you need to learn about doing that work. And that's one of the reasons why I started my own school to train nurses to do this work. Did that answer your question?
Indeed, but then of course I have some follow-up questions.
Great.
So the word advocate, as myself, my background includes having been an attorney for a number of years, not practicing presently, and also specializing in a lot of healthcare areas. The word advocate brings to mind to people who probably don't know this field very well as being somebody who's advocating for someone in potentially an adversarial type position, which is probably an overstatement of the role of the advocate, but it does suggest that trying individual patient trying to navigate the world of this complex health system. And you said, of course, it didn't even come into being until perhaps 15 years ago, but that was presumably just about the time that healthcare became much more difficult to navigate, much more confusing, much less personal, no more, friendly physicians traveling to houses, making house calls, answering the telephone, small hospitals being either put out of business or merged into, consolidated with hospitals, not knowing the line between the hospitals and the physicians, because physicians in many cases work directly for the hospital. And then of course you have the huge growth in bureaucracy of healthcare insurance. So I guess the need for an advocate was perhaps stimulated by the fact that it's become too difficult for an individual, even a person who's somewhat knowledgeable about how it works, to do it all. Is that a fair statement of what has transpired?
Absolutely. And just to reframe what you said, Mark, an advocate is a person who stands up for and speaks on behalf of a person in regard to their health care. And so one of the things we don't do in the healthcare environment, we are intimidated to ask questions of our providers, of our physicians, and there's always been a power differential between a patient and a physician. The physician might appear and seem to be more powerful because they have more education, more training, more knowledge, and we know they also get paid more than most people. And so it is uncomfortable for most patients or clients to feel comfortable asking questions of their provider. And then it worsens when they're placed in a hospital where you are surrounded by healthcare professionals who are very hurried and doing multiple tasks and don't appear to have no time for you to answer questions. So that's what I would say about that.
Okay. And of course, just bringing it into the current environment, we have a situation here where many hospitals are overburdened by a number of calamities, not the least of which is COVID-19 and Delta variant and presumably variants to come. And there's a lack of capacity. There is a lack of physical resources, a lack of human resources. And we hear daily, if we're listening to the news, how healthcare workers, doctors, nurses, clinicians, and everybody else, they're tired. And also they're on the front lines and being exposed. So it shortens the workforce. So so that only has added to the problem. And I'm sure you've had, you can explain how you feel about that as well, to add something to that mix.
So
which I don't have a question for, but
That's okay. It's all right. I would just say that my work is helping patients and families navigate the dysfunctional, silo driven, technologically impossible healthcare system with less stress, more peace of mind anywhere along the healthcare continuum. So it could be birth to death, if you will. And so people are feeling left out, non communicated to, problems not addressed, ignored, frustrated, disempowered, and marginalized. And so, unfortunately, that's where a role of an advocate can come in and meet with the patient, sit down. What are your priorities? What are 3 things you want me to help you with? How can I assist you? And get the information that you need so you can feel better about yourself, what's happening to you.
so I want to ask you a question, Karen. And for those of you who are just tuning in, I'm speaking with Karen Sanders, who is a patient advocate, has her own practice where she advocates, as she's indicated, on behalf of patients, but she also works with healthcare providers to, in effect, coach them. And she'll talk a bit about that shortly. And I'm assuming that that presumably means, okay, docs, if you want your patients to be happy and hopefully not sue you, you need to have a better bedside manner, even away from the bedside. But what I was going to ask you was, my first knowledge about the job of a patient advocate was patient advocates who worked in the hospital. And my sense of those patient advocates, being a lawyer within those hospital systems, is the patient advocate who worked in the hospital was in a somewhat conflicted position because he or she wanted to keep their job. So the zeal of their advocacy had to be tempered by the fact that they wanted to retain their job. And my guess is that hospitals decided to create the position of patient advocate, again, to sort of lower the risk of adverse litigation and so on and so forth. And so they shunted patients who were disgruntled off to the patient advocate, many times not with great success. So you set up private practice, so you have a wall, so to speak, between yourself and the institution. But can you talk about that a bit?
Sure. So it's interesting, when I started this private practice in 2015, there were people on the phone call for insurance companies, and they call themselves case care workers. And now the hot button topic is, I'm a patient advocate for the insurance company. I'm a patient advocate at the hospital, but I work only within the walls of the hospital. Or I like the VA's got a huge patient advocacy program where they will assign a patient advocate to a veteran to help he or she advocate for their access into the VA system, for example. But most advocates that are hired by healthcare facilities are within the walls of the facility, which is what you're talking about. And the other thing that's confusing to patients and families and consumers about advocates, so you can be a patient advocate, like I talked about, and not have any healthcare experience and not have any healthcare education. And then if you're in the hospital, there might be patient advocates who have healthcare experience. Then they have navigators, nurse navigators, case managers, care managers. Now there's something called nurse concierges. There are geriatric case managers, geriatric navigators. So there are all these terms that confuse the public about who best to have to advocate for me. And also in nursing, so I'm an RN patient advocate, and in our Nurse Practice Act, in most all of our nurse practices across the country, we are taught to be advocates for the patient in any setting, in any circumstance, so that we are always practicing for the better good of the patient and doing it safely and according to practice standards and doing no harm. So that's a little bit about the confusing environment and then the difference. So I work independently. I'm not beholden to any organization, hospital, or other healthcare facility, because I want to be able to speak freely and tell the patient exactly what I think, why I feel that way, and what are some really good options to help them on their path.
So obviously, there's a significant value or certain value associated with your independence. And you present another opportunity for a patient who has concerns or feels that they're aggrieved, they feel that something didn't go right in their experience in a hospital or perhaps even in a physician's office. And again, alluding to what I said before, maybe they've decided that using whatever that person is called, a patient advocate, liaison, navigator, customer service person, whatever, that those people, while they have some value perhaps in explaining the rules of the road to them, are not sufficiently empathetic or aligned with helping them if it will either create problems for the institution, create potential liability for the institution, or potential liability for them. So let's break it down a little bit, maybe in some anecdotal information based upon real life stuff or hypothetical stuff, your choice. Many things can happen, and let's just use the hospital as the model. Many things can happen on the way to the hospital, getting to the hospital, getting admitted to the hospital, being seen in the emergency room or not in the emergency room, getting transferred to a floor, and then the care that is necessary on the floor, and so on and so forth. At what point do people who use an advocate, including using you as an advocate, should they be thinking that this is not going well, or maybe this their family, it's making the medical decisions on behalf of the patient, this isn't going well, we need some help?
That's exactly right. So I would say that of all my clients, 90% are in some kind of healthcare crisis. So they might be in the emergency department. They might have just gotten a diagnosis of cancer. They might have fallen and had to have a hip replacement or a knee replacement, or they don't like their doctor, or maybe their spouse or a child or a loved one is also got a terminal disease, or maybe they are lying in a bed in a hospital, in one of our local hospitals. And so people, it's interesting because the term patient advocate is becoming, I think I saw a metric a couple of weeks ago that said that the term patient advocate now brought up 500 and 500,000 entries on Google, for example. And our inpatient advocate is a little bit less utilized, but those terms are coming available more to people's, um, awareness. So people call me because they are in a crisis. And recently, in the last couple months, I've been called mostly from people who are inpatients at one of our local hospitals. So they call because I had a woman call me on the 4th of July at 10 p.m. saying she was in excruciating pain, and the nursing staff had not come to visit her since she had her surgery at 8 p.m., for example. And she was ringing her call light and nobody would answer. So she Googled our inpatient advocate, and I popped up on her Google search. So she called me and said, "What should I do?" And she said, "I've called multiple times. I'm in extreme pain on a 0 to 10 scale, with 10 being your worst pain." She was at an 8. So I said, "Well, just hold on a minute. Have you pressed the button on your side rail?" "Yes, I've done that." Nobody's come. So we hung up, called the hospital, asked for her unit on which she was as a patient, and a person answered the phone. And I said, "This patient in blank room is in excruciating pain. came back from surgery. Nobody's been in her room for 3 hours. Someone go please answer her call light? Well, I've been sitting here for 20 minutes and nobody's rang. And I said, well, have you been sitting there for 3 hours and, and listening to all the call lights? Well, no, I just got here. Would you please go check on her? So she did. She got up and went and checked on the patient, gave her a pain medicine. And when I called back 20 minutes later, the patient had gotten to see a nurse and had gotten medicated. That's just a small example, but it's a huge issue for a patient in pain. That's just one example.
So let me just ask you a pragmatic question for a moment, and let's use that example. When somebody calls you because they have an emergent situation that needs to be addressed, unlike a lawyer, I'm guessing, you don't have time or the inclination to say, well, let me tell you what my hourly rate is, and I'm going to send you an engagement letter, and you have to sign it and then send it back to me. And then and only then will I be able to handle your case. You don't do that, I'm taking it. So, but on the other hand, you are, quote, running a business. So you can't work for free all the time. You can obviously characterize some of what you do for somebody on an emergent basis as sort of like marketing introduction, and hopefully you'll do a great job and they'll later decide that they need to engage you, particularly patients who have chronic diseases or have continuing medical needs. But how do you handle that, the issue of the economics of it?
So I always offer my first hour at no charge. And I'm also a nurse coach. So I use coaching principles to ask the patient what it is they want me to focus on. And in coaching, we take people through some scheduled standard questions to get at what they really want you to help them do. And when patients are in crisis and they call me and I'm going to answer the phone, I'm not going to say, I'm sorry, before we ever get started, just like you said, Mark. So I will go ahead and answer their questions. At the end of the conversation, I'll usually say this hour is no charge. And if you'd like to use me again, I charge $100 an hour. And you can pay me by a check, or I can take a credit card over the phone. And I would be happy to work with you, but there are some measures that we need to fulfill. I would have you complete a patient advocacy agreement or inpatient advocacy agreement. I need you to complete a geriatric assessment form, which lists all your surgeries, all of your medications, all of your treatments, etc. I would have you fill out a holistic assessment, and I would have you complete what's known as an authorization for release of healthcare information so I can get your records from a physician practice or a hospital. So that's how I work. And interestingly enough, it's pretty remarkable, but patients always say to me at the end, if I don't bring it up, well, now tell me what is your rate so I can pay you. So I think that's just generally, I found people to be very kind-hearted and realizing that my time is also important, and they've tried to honor that. So that's my business model.
Well, let me ask you again, sort of another pragmatic question, which I don't think is in the weeds. As you're providing your patient advocacy services, but knowing that you're rendering them in somewhat in your capacity as being a licensed nurse,
Correct.
do you have the need to acquire, and can you even acquire, medical malpractice insurance?
Absolutely. Mhm.
Okay, so that's a cost, that's an overhead cost you have to have, but it's necessary because there's always going to be that case, even if there was no fault on your part, where somebody's going to say, she told me to do this, or this is the way she recommended I go, and then having done that, this is what happened to me.
That's exactly right. So the other thing I do, Mark, is I work with nurses across the state. I teach a course for the North Carolina Board of Nursing called Legal Ethical Decision Making Skills for Nurses who are disciplined by the North Carolina Board of Nursing for not following their Nurse Practice Act. And one of the things I teach nurses over and over and over again is to know the tenets of your Nurse Practice Act like you know the back of your hand. And in North Carolina, there's not 9 of those. So if I practice according to my Nurse Practice Act standards, I am going to be practicing in a safe and capable manner. And so, you know, there's all this literature about what I can't do. I can't prescribe. I can't recommend different things. I can only assess, plan, implement, evaluate, educate, collaborate, delegate, et cetera, et cetera.
Because under North Carolina law, you're not considered an independent practitioner.
I am not.
Such as a physician assistant might be,
That's
for
correct.
example.
Or a nurse practitioner, or a midwife, or a certified registered nurse anesthetist, right?
Right. So basically, your nursing certification is not really sort of the issue that's involved in what you do. It's just that adds to your expertise and knowledge base. And I'm also going to assume that because of your extensive healthcare background, you have more credibility, not just to the patients and patients' families for whom you're advocating, but also with the healthcare providers who you interact with, because they know that you're just not some wild-haired person who is, you know, negative about the system and making unreasonable demands. You have a world experience that educates you and informs you as to how to interact with them. That's correct. Fair? Okay.
Very fair, Mark.
Okay. So I want to move to another topic, and we still have more to cover here, which is I found out about you through an article or two that I read that involved our quote local hospital system in Asheville. And we'll talk, you know, we're talking about what was described and still branded or co-branded as Mission, but which is a nonprofit hospital that was acquired by a for-profit hospital conglomerate known by its acronym most often as HCA. And reading the story I was reading was that, you know, and I've covered this story before on earlier radio shows, there's been a fair amount of talk, I'll say dissatisfaction, concern, informed or not informed, about what has happened to healthcare in this region following the acquisition of the Mission system, which included multiple hospitals, multiple doctor groups and clinics, and so on and so forth. And I won't say that it's the case overall, but most of what I hear anecdotally and in the newspaper and on Facebook is people believe that the quality of care in what was the Mission system and is now the HCA system, it has been degraded since HCA took over. And so let me pause for a second. I do want to talk about the lawsuit, but I want to say that what I know and what you know as well, Karen, is that with the HCA took over, it was subject, the merger was subject to some degree of scrutiny and evaluation by the state attorney general's office, who had to evaluate the extent to which the purchase price was fair and where all that money was going to go, and was charity care still going to be provided. But it's safe to say in North Carolina, and I don't know how to compare it with other states, the amount of actual review of the acquisition through the state was limited, narrow. And they set up a foundation to take the money, which was, I don't know, it was over $1 billion, I'm guessing. Don't know the number offhand. So there wasn't, you know, and there were promises and commitments made, and some of them were binding and some of them weren't. But we've been hearing for, you know, since the acquisition that many people are not happy. and the expression of the unhappiness is ranged from people saying they're unhappy to a unionization of a group of nurses that was not without some degree of controversy, closures, and so on and so forth. So I'm guessing that the acquisition, good, bad, or indifferent, has helped to generate a lot more patient concerns that have led to patients seeking advocates such as yourself.
That is excruciatingly correct. I've never been so busy in my entire life.
Okay.
Definitely.
So we're not going to throw mud. The lawsuit is protected, so we could quote from the lawsuit. The lawsuit, shall I say this, is, and you can chime in, please, is a lawsuit was filed here in state court here in Asheville and Buncombe County. It is a class action lawsuit, which means there are, I think there were 6 the last time I checked, individuals who were suing on behalf of a class, meaning that their allegations were representative not just of them, but others involved. And they sued on a variety of grounds, but one of them that sticks out because I think it's somewhat novel is antitrust, which is to say, in short form, they're alleging that the current version of HCA/Mission is a monopoly, but they're not stopping there. They're saying that Mission was a monopoly even before HCA entered the picture, when Mission way back when acquired, I guess, St. Joseph's Hospital. So that's a particular issue that I don't know if there's precedent for it. But what I do know, and then I'm going to put the question back to you, is most people on the street think that large corporate chains that acquire local hospitals, that's a bad thing. But be that as it may, it is happening, and it's happening at a fierce pace, and it doesn't appear as if it's going to stop happening, because the cost of providing healthcare services against the revenues associated with it through Medicare, Medicaid, private health insurance it generally doesn't go up. It usually goes down. And small local I won't say mom and pop, local regional hospitals don't feel like they can make it without being part of a larger institution. So it looks like this process is never going to end until and unless, Bernie Sanders and others figure out a way to provide free socialist communist healthcare, or whatever the word's going to be. So how do you feel about all those issues? I've just monopolized the conversation for a while.
That's okay, Mark. I just going back to the lawsuit, there are 6 plaintiffs who represent different insurance and payer methodologies, and their big thing is that Mission has extremely overpriced services and has caused a monopoly of up to 90% of the market share regarding Mission. And then they've also calculated those market share percentages in all of the regional hospital counties, such that I think the Justice Department or some other entity classifies monopoly when it's greater than 60% of the market share. So, and in addition to just the overpricing, and there were several quotes about the fact that Mission HCA's got the second highest charge per case of C-sections in the state of North Carolina. And they go on and identify multiple other places where the pricing is astronomical. So, and then there's that part, and then there are subsequent quality issues that are also being examined. And so my practice resides in the quality part of that equation, where I get called every day, multiple times, from clients who are extremely satisfied with the way they were treated while they were inpatients in the hospital, or where they were in doctor's offices that Mission owns, or they were in the emergency department. And all of those complaints can go from no one answered my call bell to they brought me a meal and there were no knives and forks, so I had to eat my meal, my salad and my applesauce with my hands, or my room was left unattended for 2 weeks and there's debris and cracks in the toilet seat, or the nurse was rude, or the nurses, most of them are traveling nurses. There are no nurses that are here on this floor that work here permanently. And so the quality of care is impacted. There's a lack of teamwork. There's a culture of um, not paying attention to the patient. So it's a variety of things, but my work has to deal mostly with the quality issues.
Okay, well, that's good to know. So basically, if I can go back to that point, the lawsuit does allege a number of things about lack of quality, lack of care, cleanliness, hygiene,
Mhm.
lack of personnel, call service, and the like. But as you say, it leads off, or appears to lead, with the economic issues. Besides uh, the comparative cost of a cesarean section in one of the mission hospitals, or presumably in the OB department. There's also an allegation that insurers are charging patients or employers who cover their employees significantly higher premiums in the area covered by HCA Mission, which is Asheville and the surrounding counties, than even in other cities where cost of living generally might be higher, such as Charlotte or Raleigh, Durham, or whatever. Which, again, if those numbers are true, that's interesting and suggestive. It's not altogether damning. There could be reasons other than an unfair antitrust monopoly for why that occurs. But that's the economic part. And that's not what you're dealing with. So if somebody calls you up and says, I was overcharged, or I paid more than I should, or I was charged for something and I didn't know about it and I thought my insurance covered it, you don't get on that ship, essentially.
Most of the time, I don't. I always recommend they get a copy of their own medical record. And getting a copy of your own medical record is cumbersome and somewhat, well, it's just difficult to get that from Mission as a paper copy, but it's your right as a US citizen to get a copy of any hospital or other medical record. And there's a whole lot about that on the website for um, health care information for the government. And then to look at that medical record, probably with a healthcare professional, to compare what was ordered by physicians and what you were charged for. And then I would hand them off to an accountant or a business manager that had worked at the hospital, so they can help them figure out what's true and what's not on their charges, on their bills.
And I guess, potentially a healthcare lawyer could get involved in that, but they probably don't do much good unless you can show that there was something absolutely fraudulent, such as being charged for something that they never got, as opposed to being overcharged for something that they got that was substandard. But there
So
may be, go ahead.
I would just say that in 2018, the federal government enacted a law that says every hospital must list every single charge and how much it is on each hospital should have something called a cost estimator. So you could go, I always turn to the Mayo Clinic as my gold standard to look at things. So if you go Mayo Clinic cost estimator, you go to their website, and then it says, what are you looking for? And you want to say, well, my doctor says I have cancer and they want to do a CT of my abdomen with contrast. So you type in CT abdomen contrast, and you have to do a few other steps. And Mayo Clinic's cost charge for that comes right up at $2,800 some dollars. So then if you went to do that at Mission's site, for example, it's a little bit more cumbersome. And then if I'm a healthcare, if I have no healthcare, then I can't get that information from the website. I have to go talk to a quote unquote client representative. And so the good news is it's a law that hospitals have, that there's this law requiring hospitals to have that information. The bad news is it's cumbersome, except there's some great hospitals that do a good job with that.
I've heard the term or the phrase, if I have it right, this sort of no surprise billing. Is that law that you alluded to different from that, which is to say you can't, a hospital can't charge you for something that you thought was covered by your insurance and isn't, unless you were advised of that issue going in? For example, an anesthesiologist who administers the anesthesia in a surgical situation may not, and often isn't, a employee of the hospital, and so he or she makes their own charges. Or is that a different set of rules and laws as far as
It's
you know?
probably a different set of rules and laws, and that's why I recommend people with problems with their billing to work with billing professionals, patient business office accountants to who know patient billing, because it is extremely complex and fraught with all kinds of excessive charges that, like I said, you have to correlate with the patient's physician orders. And it's really difficult. I'm just going to say that right now.
Again, to just make sure that we distinguish between what you and patient advocates generally do from things that are in the bailiwick of someone else. If many times the adverse experiences that patients have to do with services that are, quote, not covered, or services that are in prescriptions, for example, that are supposedly covered, but then there's a big surprise there. Like, let me just shift to like pharmacy, for example, prescriptions. There are pharmacy benefit plans that work in tandem with an insurance company. And if you have one of those plans, those PBMs are in charge of, handling the reimbursement associated with prescriptions. They work off of something, and I don't, stop me if I'm not near kin, called a formulary, which is there are certain drugs that they say at the beginning of the year, these are the ones that we cover. And then there's a whole bunch of others that they don't cover unless you get pre-authorization, which means that the doctor has to fill out some more forms. And then even if it's covered in one case or another, there may be a separate deductible before you can even get the first dollar paid for. And if you meet the deductible, then you have the co-payment. People complain a lot about not being able to access the right prescriptions because they can't afford to pay for it, or they can't cross over to this place where the doctor says, this, you need prescription A. And most doctors, in my experience, they say you need A, and they're not checking first to see whether the patient's insurance can cover it. So what about all those people and all their complaints?
Okay, so first thing I would say, every single year, I'm going to only speak about Medicare, okay, for example. Every single year, our healthcare plans change every year. And it is incumbent upon all of us to learn what those changes are. So if you are over 65 years old, the government has a program called Senior Health Instruction Program. I'm missing it's the SHIP program, SHIP program. And it's stronger in some states than others. In North Carolina, we have a very strong program. And here in Buncombe County, we have Land of Scott, or the Council on Aging has Medicare instructors to teach about all the changes in Medicare, which is Part A, which covers hospitalization, Part B, that covers outpatient and procedures, and Part D, which is drug plans. and they do a phenomenal job, and they usually offer 1 to 2 every month. And so it is now August, September is tomorrow, and the enrollment for these plans is going to start like October 10th and go to December 15th. So even I, Karen Sanders, with 45 years of healthcare experience, I go to one of these in-services and trainings every year because I only have like one drug, but it's expensive. So I have to go and learn how I can find the cheapest plan that takes that drug. So number one, the plans are going to change every year. Your insurance plan is going to change every year. Number two, the insurance companies who pay different pharmacies is going to change every year. So this year I was told that Walgreens and CVS were going to be my pharmacies. Well, I don't go to Walgreens and CVS. I
Yes.
go to Sona. So then you have to say, then when you go to your pharmacy, then you have to say, is this drug on your formulary? A formulary is a list of drugs that each pharmacy carries. Well, that changes every year because the suppliers change every year. So you have to check three things. You've got to check, what does your Medicare plan say, Part D? What's your drug plan? Number two, you have to check with your pharmacy. Are they covering that drug? And number three, are there any discounts that you can do that? And number four, on the Medicare site now for Part D drugs, you can go to medicare.gov and check on your Medicare, your drug plan, and you can type in those drugs and it'll tell you, give you a list of pharmacies where you put in your zip code and who's offering those drugs and the cheapest to the most expensive. So there's lots of resources for people to find out, especially about drugs. And lastly, physicians are extremely busy and they usually don't have time to know who's got the cheapest drugs. One other thing, there's a great thing called goodrx.com, which you can get these incredible discounts for your drugs. So I pulled up, I had a really bad virus not too long ago, and I pulled up to the window to get my drugs, and she said, you know, this is the brand name, but if you get the generic name, you can go sit in your parking lot and find out what's the generic name and bring around this GoodRx form, and it's going to be $100 cheaper, which is what I did. So GoodRx is another site. So to help consumers get the cheapest prices, they have to do some education. Go to medicare.gov, find a place in your community that has classes. Know that everything changes every year, and it has to be incumbent on us as people who consume healthcare to upgrade ourselves.
So one caveat I'll just throw in there, and again, not to get too specific, but for Medicare, for the pharmacy benefits, the formulary, as you indicate, is set annually. And if you choose a particular prescription benefit plan, that's the one you are more or less locked into for the year. So the conundrum or the problem that people can run into is in January or September, October, whenever you have to sign up, you might be taking A, B, and C drugs. And then during the course of the year, you go to a doctor, you acquire some other condition, which requires you to take something else. And if you happen to have a plan whose formulary doesn't include that, and it's an expensive drug, there more or less is not too many options for you. You can't jump ship and go to another pharmacy benefit program. The GoodRx is something that I think people like to use, but GoodRx oftentimes doesn't work if you're Medicare or Medicaid. So it's a lot of hoops to jump through, and they're not all fail safe. You almost have to keep on top of it constantly, even
I agree.
once you make your choice.
You can also ask your physician to order you a drug with a generic brand as opposed to the designer brand that you see on television that people are trying to get prescribed. So oftentimes physicians say, you can just say, I can't afford this drug. And then the physician can say, well, let me see if I can find some kind of a generic substitute. And a lot of people forget that they can do that also.
Okay, well, let's go back again to what UC do and how you're assessing things in the role that you principally play as patient advocate. Again, I think to sum up what you've said, and let me again remind people, this is Karen Sanders, who I'm lucky enough to have on a show, who is a patient advocate, and we're talking about the wild world of healthcare, and how to try to navigate and how to get assistance through a patient advocate or patient advocacy program. You're there in many cases as a, I don't mean this disrespectfully, but a Band-Aid. You've got something that needs to be done for someone. It involves a patient's concern about lack of care, lack of attentiveness, not, and worser is not a word, but worse things like, they were supposed to get a particular thing intravenously, and it hasn't shown up, and they're getting the runaround, or they were supposed to be put into a room after coming out of the emergency room, and guess what? There's no beds available, so they're sitting in the hallway. And now with COVID, they may be sitting in a hallway, and there may be people who have the virus. I think maybe a fire person is possibly a better word, which is you have to jump onto the truck and race and try to get something done. And the environment that we talked about earlier, which is fewer resources, more expense, more consolidation, less choice, monopolistic power dictates that you can charge more because what are the other choices? 0 to none, or you can travel 200 miles to go to another facility. These issues are going to, they seem to me like they're just going to get worse. I don't see a long-term systemic solution. But you have to be more upbeat than that. What's your view of things?
Well, I'm going to just say that I am a believer in Medicare for all. And a lot of people say, well, that's just socialized medicine. Well, we have socialized medicine already. We have Medicare, we have Medicaid in some states, and for God's sakes, we have the VA system. And if you look at the outcomes of elders who are like, they might have 2 or 3 comorbidities or diseases, and then they start on Medicare, you look at these huge population statistics over time, and the population statistics for better health outcomes are pretty apparent with the Medicare system, and also, with the VA. So I think that what we have is total chaos in our healthcare system, with insurance companies are charging whatever, drug companies charging whatever. Then we have all these tentacles of monopolies and lobbyists and everything else. So I would be in favor of Medicare for all. And yes, there are problems negotiating with Medicare. There are problems of being in the VA system, but it's a lot more efficient, really.
Well, in support, although I try to not be partisan on this, in support of what you're saying, I don't think a legitimate response to Medicare for all isn't that just socialism? Because
Right.
obviously socialism is a name, and we're not talking about the government owning the hospitals. We're not talking, of course, the VA being the relevant exception. We're not talking about the government owning the pharmaceutical companies, which is, sort of a key feature of socialism. But we have social programs. And as you point out, there are many, many problems with the bureaucracy that we call Medicare and Medicaid. But we're in a period of time where there's a lot of good questions and a lot of concerns, but there's not a lot of will on the part of people that can make the change. Witness North Carolina as being an example where they have not been able to get Medicaid expansion passed. And the only reasons that they can come up with that have, I don't know, some is the state will have to pay something, and we don't want the Fed. And none of that makes a whole lot of sense when you know that the federal government pays the lion's share of the Medicaid costs. Whether bringing a lot more people in the system through Medicaid will overwhelm the healthcare system, maybe temporarily, but once you have to address the fact that people who previously had no access to healthcare now have access to healthcare, then you just have to staff up to meet that.
Mhm.
So, you know, again, I'm not necessarily a person who wants to speak out in favor of Medicare for all, but I don't see anything significant happening. And I guess you don't necessarily either, but that's where you see a solution.
Yes, that's where I see a solution.
Again, not to bring us back to this lawsuit for a second. Again, it's too early in the process to know where it will fall. I, you know, speaking from some experience as a lawyer, think that if all of these things that are bad that are happening in the hospital are true, or most of them are true, you know, not enough service, not enough people, hygiene problems, closures of certain hospitals, closures of various departments, access more difficult, geography, you have to travel long. If all those are true to an extent, the idea of being able to have a antitrust case, which depends on being able to prove a monopoly. Now, you mentioned what's a monopoly. Well, it's not quite in the eye of the beholder, but it's somewhat in the eye of the beholder. That you'd have to show that their market power that they have in the area that they provide services is such that all of these things about anti-competitiveness is the result of that. And I don't have a lot of optimism about it. You're not a lawyer, but what's your sense of it?
I'm not even, I'm just going to pay attention to the
You're
quality of
knitting.
care issues. And I actually have more optimism about it. And that whole thing is being taken, you know, I send my questions to the attorney and some of the plaintiffs who file the suits. Meanwhile, the quality of care is horrific. And we need more advocates and more people to help our patients and families not suffer through such horrific staffing, subsequent issues regarding short staffing, and myriad issues. So that's where my work is,
Well,
Mark.
before we end, I want you to please tell people where they can go to reach you and your website and all of that. Could you do
Okay.
that?
Yes. So you can Google RN Patient Advocacy NC. Google RN Patient Advocacy NC, and that will be me popping up on that webpage. And also, you can go to my website, rnpatientadvocacync.com, rnpatientadvocacync.com. And you can also Google Karen Sanders, RN Patient Advocate, and that's how you'll find me. And then once you get to my website, you can fill out a contact form, which goes to my email, and I will respond to you in about 2 business days. So that's how people find me.
Well, I want to thank my guest, Karen Sanders, patient advocate. Great show. We'll love to have you back again. Thank you so much, Karen.
Thank you, Mark. Thank
Take care.
you. Thank you.
Take care.